Courtney Casserly, Dr. Ario, Mirian, Dr. Alexandra Muccilli, Dr. Dalia Rotstein, and Dr. Anya. Come on up. Every time I see Dr. Yes, she has really cool shoes on.
But look at this lady's
But yours are really cool. All right. Thank you all for being here. It's nice to see you. And again, sacrificing your Saturday to be with us. I hope the patients realize how big of a deal that is. So we're very grateful. So let's start with introductions. Who are you? What institution are you from? And why neuroimmunology?
Okay, these are really, some are easy and some are hard, right? Anne Ye, I'm a pediatric neurologist and a specialist in pediatric onset MS and neuroinflammatory disorders, which when I was a resident, when I was going through training, I didn't think existed. So I chose a specialty that didn't exist because I wanted to know about it and why people thought it didn't exist. I'm at SickKids and the University of Toronto. And actually, fast fact for me, I was born in the United States. And so I do carry citizenship from that country that's suffering so much right now. So I am just very happy to be in Canada, everyone.
And listen to this, small world, but Dr. Ye and Michael Devlin went to college at the same time at Harvard.
That's right. He was, I'm not going to tell you what year we graduated because it was just 2 years ago, but Michael was in a different residential house from me, but we overlapped by many years. We were just a year apart in graduation.
All right.
I'm Alex Muccilli. I'm an adult neurologist at St. Michael's Hospital. I also work at UHN and Trillium. I got interested in rare autoimmune diseases because people usually end up in the hospital, and I'm very interested in acute neurology. And I think it is an avenue that has really evolved over the last 10 years, and we now do a lot more than just diagnose and adios, which is what we used to say about neurology in general. We have a lot of therapeutic options, and it's a great time to be a neuroinflammatory specialist.
Thank you.
Hi, everyone. I'm Ario, Mirian. I'm at St. Michael's Hospital. I'm an adult neuromuscular neurologist with an interest in myasthenia gravis. And I guess, what brought me to that area with the neuromuscular neurology is that, I think all aspects of it were fascinating, clinically, neurophysiology, and it has such a so much is being developed within the myasthenia gravis space from a therapeutic standpoint. So very exciting area, and happy to be part of today.
Hi, everybody. I'm Dalia Rotstein. I'm a neurologist specialized in MS, NMOSD, and MOGAD at St. Michael's Hospital, and also affiliated with the University of Toronto. So I guess part of what motivated me to go into MS and rare neuroimmunologic diseases was my grandfather. So my grandfather was a really dynamic person, but unfortunately he contracted the polio virus at a young age when he was in his 20s. It was just a few years before the polio vaccine became available, and he suffered severe neurologic consequences. So he became weak in his legs and also one of his arms. And at that time, there really wasn't a lot of hope for people with neurologic conditions. Basically, my grandparents, they lost a lot of their friends, and he was told he was never going to walk again. And he did learn to walk with crutches. He learned to drive his car again using hand controls, and he had a very full life. But I think there's much more we can do today for people living with neurologic diseases. We have more accommodations, but we still have a long way to go.
Thanks, Dalia. So I'm Courtney Casserly. I also work in multiple sclerosis and NMOSD and MOGAD, but in London, Ontario, so just a little further down the highway. And I'm excited to be here. This is my first patient information day. I've been working with Dalia on her Canoptics registry and trying to bring some of that research and sort of connection to London, because Toronto is such a big and exciting place. It's exciting to work in NMOSD and MOGAD because, as people have alluded to, there's new therapeutics, there's new treatment options. So an exciting time to be able to work in this area. And fun fact, I did my fellowship here at St. Mike's And my son, Jack, who's here right now at the top of the CN Tower, was born at St. Mike's. And so he refers to himself as from Toronto. So I feel like I have a small connection, but just really excited to be here. Thanks, Dalia.
Thank you. So a couple of things. Something happened to my slides, but I didn't get to show it to you. But something amazing happened a few weeks ago. I don't remember the name of the issuing body, but Dr. Yen, Dr. Rotstein individually, what is it?
Canada's Drug Agency.
Canada's Drug Agency just awarded both of these lovely doctors each upwards almost of 300,000 Canadian dollars for their individual research projects in rare neuroimmunology. Please give them a round of applause. This is a huge deal. Huge deal. And they will discuss their initiatives later this afternoon if you're interested in learning about it. But I had an entire beautiful slide dedicated to this. So I just wanted to make sure that I acknowledged it. So the purpose of this panel is to really talk about rare neuroimmune, neuromuscular disorders at a high level. We are going to have breakout sessions later where you can go in depth and ask questions directly to the experts in much smaller settings. But right now, I just want to, understand from our lovely experts here about rare demyelinating conditions in general. So the first question, and we can go across the panel. Can you share your perspectives on rare neuroimmune conditions as a group, how they present among your patients, similarities, key differences, and common themes?
That's a really easy question, Samira. So rare, I think one of the things in the pediatric population is that neurologic conditions are relatively rare among children. Children are usually healthy. And so when a child comes in with a neuroimmune condition, it's often very hard to recognize from the perspective of the emergency room physician or the first physician that sees you, because the expectation is that it is not neurologic. Most people might expect that it would be a problem with the hip, or, if someone's not walking, a problem with the hip, or a problem with, a strained muscle or something like that. So I would say the similarities within whether it's myasthenia gravis, NMOSD, or MS, is that there's a lot of head scratching that happens initially. Samira even talked about this. It took 5 weeks to make the diagnosis. We believe we can make the diagnosis faster than that now, much faster, just because of the way we've talked to people around the world and things like that. But the thing that brings them together is that it is very hard to recognize them and figure them out at the beginning. And they all look alike at the beginning.
Thank you. Dr. Muccilli?
Maybe I'll talk a little bit about autoimmune encephalitis. It's a rare condition that causes people to have psychiatric symptoms and seizures and abnormal movements. And oftentimes, initially, young people go to the hospital and they're behaving bizarrely, or they have more anxiety than usual, and they're misdiagnosed as having a primary psychiatric condition. And that often leads to a huge delay in diagnosis, which has an impact on their long-term outcome. Same thing with seizures. People will start having seizures, and it's, unbeknownst to the medical team, we don't know that inflammation is driving those seizures, which makes them very difficult to treat. And so this can look like a lot of other neurological conditions. And, I think we've gotten better at identifying features of these different presentations that make us think about an autoimmune cause, but it's still very challenging. It's challenging for us, and we're experts, and it's certainly challenging for people that are not seeing individuals with these conditions all the time.
So from a myasthenia standpoint, it presents with fluctuating, typically painless muscle weakness. And although there are certain muscles that are characteristically weak, there can still be, similar to what's previously mentioned already, a diagnostic delay. And I think another thing about it is that, every patient presents it slightly differently and has a different course as well, which a big component of this condition. I think similar to what's already been said, but an ongoing kind of process is not only learning about the patient's condition over time. Also, there's a big patient education aspect to it too. So there's learning happening at both sides, or both, especially early on. So I think that's something that's also a really shared component of this condition too.
So I focus primarily on NMOSD and MOGAD. So one of the big challenges when these diseases present is that they can look very similar to multiple sclerosis, which is a much more common immune disease of the nervous system here in Canada. So often people get misdiagnosed at the outset as having multiple sclerosis. So it's really important that we have good education about these two conditions, because we do have a simple blood test for each. So the NMO antibody for NMOSD and the MOG antibody for MOGAD. But the clinician who sees the person for the first time who's presenting with neurologic symptoms has to think about the possibility of that diagnosis and send the blood test in order for the correct diagnosis to be made. So some of you may have had, the experience of having diagnosis delayed. These antibodies became, I'd say the tests for the antibodies became better around 2015 to 2020. So if you were diagnosed before that, one of the challenges may have been that we didn't have the blood test available. But today we are fortunate. A lot of the diagnostic methods have improved, but we do need education so people think about this possibility and send that blood test.
So I echo a lot of what's been said. I also work primarily with NMOSD and MOGAD, as well as multiple sclerosis. And things, as you get a sense from the panel, things are changing rapidly over time, right? Like the rules are changing, the tests are changing, the medications are changing. Just since I've come into practice in 2016, we've had a whole slew of new medications that have come out to treat primarily NMOSD, and now MOGAD's kind of catching up. But my sort of one thing that I think is a common theme is access to medication. That's sometimes a struggle trying to get that medication paid for. I don't know what it's like in the States, but in Canada, as you guys all know, there are certain, processes that we need to go through to get this paid for. And so that's something that I think we can advocate for as a group, but something that you don't always think about. I know Ario, I think, thinks about it in MG, thinking about it in NMOSD, as we have these new options to making sure that they're available and that we can use them when we feel that we do need to.
Thank you. Perfect segue to my next question, talking about change. Could you each share your views on how therapies for rare disorders, like the ones we're discussing today, have evolved over the last decade? Are there any interesting trends that you see in terms of mechanisms, approaches, and types of therapy? So we'll start that way and come back this way.
Sure. So absolutely. I remember, I think it was 2019 was when we had the American Academy in Philadelphia, and that was a big year for NMO. There were a lot of new treatments that were coming out that we had access to. And so really exciting time as a clinician. I had things to offer. I had medications that were specifically targeted for NMOSD. The price tag, though, sometimes makes it difficult to get access to these medications, and whether people have private or public coverage. So definitely we see lots of targeted therapies. As we get a blood test that we can test for antibodies for, we also have targets for those antibodies. So a really good time, to in terms of developing treatments, but then also access then becomes the challenge, and how to advocate for those medications.
Yeah, so just to echo Dr. Casserly, it's been such a time of excitement for both NMOSD and MOGAD. The number of therapies and the evidence for those therapies has just exploded over the last few years. So in the past for NMOSD, we just had drugs which were used off-label. And what that means is that doctors, learned through trial and error that these drugs worked for the condition, and we knew they modified the immune system, but they weren't actually proven in clinical trials. So beginning in 2019, as Dr. Casserly said, we had the first clinical trials published showing evidence-based therapies for NMOSD. And we've had 4 therapies that had successful clinical trials that are now approved for use here in Canada. The access is still somewhat restricted, but in the right situation, we can usually get those drugs covered. So that has represented a huge advance in treatment of NMOSD. For MOGAD, MOGAD is a complex disease because there's a huge range in terms of severity. Some people with MOGAD just have a single attack. Some people have multiple attacks. So some people with MOGAD may do very well off of treatment. And of course, we don't want to subject people to treatment that can have, a psychological burden as well as some associated side effects if they don't really need it. So a part of the last few years has been learning about who really needs treatment for MOGAD and who doesn't. And we have several therapies that are being used off-label for MOGAD with good rates of success. But what's really awesome is there are also some clinical trials ongoing now for MOGAD. So we may have, better quality evidence within a few years and new treatments for MOGAD as well.
Yeah, so from the myasthenia standpoint, things have changed considerably in the last several years. So, for a long time, patients with autoimmune myasthenia gravis were being treated with what we call conventional treatment, which cornerstone of that would be steroid therapy. But in the last several years, there's been a lot of clinical trials on what we call targeted therapies. And these have been really a game changer for a lot of patients that have generalized myasthenia gravis, can't tolerate what we call conventional therapy, or are just not responding enough to what we previously only had. And so this has been a major advancement in the field. But like Courtney mentioned, access, clinical criteria, and so forth are big things to consider for these newer and more expensive treatments. But it's been a big component of myasthenia research in the last 8 to 10 years.
Yeah, I think it's worth mentioning that there's certainly regional inequity as well. I mean, the drugs we can access in Ontario are not the same as the drugs we access in Quebec or BC. And certainly, if you live in Northern Ontario, there's no autoimmune neurologist up there. And so if somebody doesn't refer you to our clinic, or we don't see people by Zoom, then you may not have access to the same therapies that we have in a large clinic like the Barlow MS clinic. We are maybe the face that our patients see, but if it wasn't for all of the nurses and drug access navigators and administrative staff, we wouldn't be able to do what we do. I also think it's worth acknowledging that, while people who have the aquaporin 4 antibody can access maybe the therapies that are approved, there are a lot of people probably here who don't have an antibody and have a condition that, there's no approved therapy to treat. And we have to work really hard to get drugs for those people. We also don't necessarily know if somebody with antibody negative NMOSD has the same disease biology as somebody else. And we may need to use different treatments, and access to these treatments is even harder if you don't have a truly recognized kind of disease entity. And that's a major challenge. It's an ongoing one. And, we're really blessed to have the support of our clinic in helping us advocate for our patients.
Raise your hand if you are aware that you are seronegative for your condition. Yeah, that's a lot of us.
And can I just say, in NMDA encephalitis, the most common encephalitis, we don't have an approved therapy yet. So even people who do have an antibody sometimes don't have approved therapies. And it's really important to acknowledge just how much of our work is advocating for access for patients.
Alex, I want to sort of segue from that point, because having an antibody doesn't mean you have access. If you are under 18 years of age, there is only one approved therapy, and that's only if you have an aquaporin 4 antibody. So the pediatric space is so different from the adult space at this point. But I'm going to take you back, because I saw some names on the list of patients that I've known for many, many years who are now in the adult world. And I'm just about 6 months older than a couple of these other clinicians up here. And I remember when we didn't even know what the antibody was. We didn't know to look for the antibody. We didn't know what to treat with. And I actually, it's kind of sad to say, I remember when the aquaporin 4 antibody was described and when NMDA antibody was described. And at that point, we have come such a long way because at that point, we thought, should we give steroids then? You know, what should we do? There were no targeted biologic therapies at the time. There was no approach to whether to use steroids. Using IVIG, which all of you have probably heard of, using IVIG was, should we do this or should we not? Well, they do it in another disorder that's not being represented here, Guillain-Barré. Maybe we should do that. So there was a lot of lack of knowledge. In the pediatric population, we do what we do, but we don't have regulatory approval. And it is incredibly difficult. If you think it's difficult to run a trial for adults, it is 10 times more difficult to have a successful trial within the pediatric population. So part of one of the really big reasons I'm very grateful to the Samira Foundation is that that advocacy for access to therapies, as everyone on this panel has talked about, is like the core of what we want to do. And without partners like this and you, we can't get to that next stage. So we've come a long way, but we're not there yet.
Absolutely. And if you haven't looked at the agenda, this afternoon, there is going to be a session dedicated to exactly this, about how can patients and caregivers like you and I help support the efforts of these clinicians and researchers to advance the understanding of these disorders, but to also help get access to these therapies that are becoming available. So if that is of interest to you, I highly recommend tuning in for that later this afternoon. Third question. With autoimmune encephalitis, I know I say it like a Brit, but myasthenia gravis, MOGAD, or a Canadian, MOGAD and NMOSD. What are common symptoms, comorbidities, and other challenges that your patients face? And how do you help your patients face them and address them? So we'll start here.
Symptoms, comorbidities, and challenges. So I think the symptoms people are, in this room may be aware of, but, when you have a life-altering neurologic event where Samira pointed out her vision, right, where your vision is gone, where you have a spinal cord event, or if you have something that strikes your emotional centers, your emotional and your limbic system, your ability to control your emotions, the repercussions on you and your family, I really want to mention family, can be huge, because even if you don't remember being that sick, your parents and your loved ones will always remember, and it will stay with them forever. So I would say this is not, in the traditional way of talking about what we call a comorbidity, it's not really a comorbidity. But one of the things that we really have become aware of over the years in dealing with this is that PTSD among family members, amongst the people that suffer from the problems themselves, is one of the biggest things that we need to learn how to deal with. There are other things that within the pediatric population, developmental issues, getting back into school, learning how to function when everything is not as perfect as it was, even though other people on the outside think you look fine. Huge deal. And then I would say that accompanying that, the other aspect of the emotional impact that takes on individuals, depression and fatigue, it's something we've been very, very focused on for many years, because we find that even if the symptoms are gone, this other stuff stays. And I think it's really important for you guys to know that we're here for you, and that our teams are here for you, and that you should not be afraid to say, hey, this is really bad. This is bugging me and I need help.
Can you raise your hand if you're a caregiver, a family member, or a loved one? Wow, that's a lot. So being here today is equally as important for you too. Thank you for being here and thank you for taking care of your loved ones. Dr. Muccilli?
So I think to add on to what Anne said, there, a lot of people come to the hospital with neurological symptoms and don't have NMOSD or encephalitis or multiple sclerosis. But they may have neurological symptoms that are not explained by, a lesion in their nervous system, as we call it. And that makes diagnosing these conditions very challenging. And sometimes we misdiagnose either by saying somebody has an inflammation problem and they don't have one, or by saying they don't have an inflammation problem and they do have one. And both are dangerous. I echo what you say about it. It has significant PTSD for our patients. I think also for us, I've been really marked by misdiagnoses that have occurred, that I've made mistakes too. And I think it's an important thing to acknowledge that the mood component of these diseases that seems to be, ramped up at the beginning, either because people are worried about their symptoms or because it's actually a part of the disease itself, is really challenging, I think, for everyone.
So from a myasthenia standpoint, as I mentioned before, it can cause fluctuating weakness. And so it can affect vision, chewing, swallowing, speaking, strength in the arms and legs, and breathing. So patients are at increased risk for other autoimmune conditions, but big challenge or big component to it is there is an adjustment to now a lifelong condition. So there's challenges with that. There's a big fatigue component to it. And that can also be associated with a variability in the weakness that I might not be able to detect, on exam, but certainly makes an impact in many areas of life. So occupation, socially, and also there's similar to what's said before, depending on how severe the condition is, if a patient was in the ICU prior to diagnosis, there is could be a lot of anxiety in regards to maybe the unpredictability or perhaps potential worsening again to that degree. So those are a lot of major challenges that I see.
Yeah, so, besides the symptoms of the attack itself, we find that there are a lot of residual symptoms, I would say, that people with NMOSD and MOGAD live with. So, often people improve with the therapies we give around the time of the attack, but unfortunately, they don't go back to where they were before. So there's both a physical toll of the disease on a daily basis. And then, as some of my colleagues spoke about, there's also, the issue of psychologically adjusting to your new normal. And how is that going to affect you on a daily basis in terms of, your ability to work at your job or your interactions with your spouse or with your children? So that takes a lot of figuring out. And just to speak to some of the symptoms we encounter in NMOSD and MOGAD, which are two of the diseases I work with, we found that pain is often a very prominent part of the disease on a daily basis. And I will confess, we have different therapies and also other approaches for dealing with pain, but, they're still suboptimal. And we often have to explore, we often have to try different things. It's a bit of a trial and error approach. I think it's really important that you share with your physician if you feel like your pain is not under good control. We have pain specialists we can refer people to. We have a multidisciplinary team, so we can get people like massage therapists involved. So there are, there are always new things we can try, but I just want to acknowledge that even after the attacks are managed with good medications, often people with these diseases are living with a lot on a daily basis, and that takes a lot of courage.
So I agree with what's been said so far in terms of those invisible symptoms. And I don't know that they're necessarily invisible, but the things that, we control relapses, and then people will report things like fatigue and pain and bladder symptoms that aren't immediately visible. Those things are sometimes difficult to treat. I think one strategy that has maybe been successful in the past is trying to collaborate with other specialties. So Dalia mentioned pain clinics, multidisciplinary approach. So some communication with, bringing in another specialist if we need to talk about a particular symptom. And we don't always get it right on the first try, but working on it and trying to bring in some kind of expert advice and talking about those symptoms and coordinating with people's family doctors if you have one. Because as we get better in terms of our disease modifying therapies, we realize that there's this whole other realm of symptoms that people are dealing with. And those symptoms are just as relevant and important and often have a huge impact on day-to-day life, but perhaps aren't as responsive to those immunomodulatory therapies. And we may need to think about other strategies.
Thank you. I just wanted to say a few things. So, as challenging as these conditions are and as unfair as it seems to get, these diagnoses none of us asked to get, I hope that you all walk away from today with several things, but just I wanted to note a few. The first is that you are not alone in this journey. I hope that's evident from this room. I mean, at least from today onwards, if you need anything, whether it's from one of these experts or the foundation or another patient or another caregiver or our therapy partners, I want everyone to know and feel that they are well supported and not going to navigate any of this alone. Second, yes, these are challenging, of course, but I know that we all have it in us as humans to pick up the pieces and move forward in navigating our new normals. We cannot let these diseases, these diagnoses defeat us, consume us, or limit us in doing the things that we want to do. Our dreams may look different, our aspirations may change, but life is not over because of these disorders. And the third thing is that, of course, we rely on our experts for helping us managing these disorders, but they also rely on us. It's very important for us, and the onus is on us as patients and caregivers to effectively communicate what's going on with us, because it's a team effort to help us move forward. So I just wanted to convey that message before I forget. And the last question before our group photo and lunch, yay. And I wanted to end this on a positive note. Given all the recent scientific and medical advancements in the fields of neurology and immunology, what gives you all hope for the future in terms of promising developments, whether it's diagnostics, treatments, or managements of AE, MG, MOGAD, and NMOSD? We'll start with you, Dr. Ye.
That is the best question in the world, because go autoimmune neurology is all I have to say. When I started this, neurology couldn't do anything. We couldn't fix anything. I'm telling you that. And I didn't become a neurologist not to be able to help people become better. Now we have treatments, we have targeted treatments. There is so much biology that has been learned over the last decade that I have confidence that as long as the efforts to ask the right questions are supported, we will get better and better at this. And in fact, all of the trainees in neurology want to do what we do now because we can make a difference. Okay.
Love that.
Maybe I'll take a different approach. I think, no, this is all true, but I don't want us to all repeat each other. But I think in the age of technology, there's a lot more awareness of rare disease, and that's a very important thing. Also, the pandemic helped in some ways because it allowed us to use virtual visits as a way of seeing patients. And there are a lot of rare people with autoimmune disease that are rare, that are admitted in some hospital that's not Toronto. And to be able to assess those patients at a distance, helps them do better because they get diagnosed sooner and we can connect them with the resources and the treatments that they need. And I think that is happening more and more with education, with physicians not just being in their office seeing their one patient, but by being advocates and outspoken. And that's a really, really critical part of our job.
So in myasthenia, it's been very exciting because there's so many new novel therapies that work quite well for most patients. But I think the thing that makes me most excited is that I think with ongoing research and future research, we're going to learn a lot more about which patients will respond best to which medications. So kind of in the broad area of biomarkers and understanding patients' disease in a much more specific way to know what specific medications have the best chance of working to get symptoms under control a lot faster, I think is a very exciting area in myasthenia gravis and something that might be changing quite quickly, hopefully in the next 5 or so years.
Yeah, so I just want to share my personal experience from NMOSD. When I started my career as a staff neurologist in 2015, when I had patients with NMOSD come through the door, I used to be very concerned about them. I unfortunately, saw a few people who had bad attacks and deteriorated quickly, became blind. I mean, really devastating consequences. And our outlook, has completely transformed within 7 years. Like now, when I have somebody with NMOSD come through my door, in a way, I'm grateful they have NMOSD and not MS, because with MS, we know people get worse over time. With NMOSD, we have such powerful therapies that, our goal today is to stop the disease after a first attack. And as long as a person, doesn't have other attacks, they're not going to accumulate any more disability long term. So I think today, NMOSD, we're very hopeful about NMOSD. We still need better access to the different therapies. So we still have work to do. But I think in just 10 years, it's a completely different outlook for people living with this disease.
Great. I agree with everything, but in the spirit of Alex, I'm not going to repeat anything that's been said. I just want to say probably the patients. I would say as a group, we have a small NMOSD and MOGAD clinic in London, Ontario. And as a group, people living with these diseases are motivated. They're, with the age of the internet, up to date. You know what's going on. You're communicating with other people in Canada and the States. You have great questions. People are resilient and motivated to kind of get to where they want to be. So that's been a really exciting part of working in this space. And then the other thing is collaboration. So being able to work with advocacy groups, being here, seeing these like wonderful opportunities come up where people are advocating on behalf of themselves and on behalf of others. So that's been like a really exciting space that, as Dalia said, didn't exist like when I started working, and now is just a really exciting part of working in this area.
Fantastic. Please join me in giving our featured experts a round of applause. Thank you.